Well, the laryngeal oral airway is sort of a perfect compromise between a laryngeal mask airway and a traditional oral airway. The laryngeal mask airway can be quite effective in providing ventilation and capnography, but the level of sedation that's required for it to be in contact with the airway requires a lot heavier level of sedation than most of us would like to offer in an office setting. An oral airway is not going to stimulate the patient, but unfortunately it's not going to provide that beautiful, great oxygenation and capnography. So this airway is used as a perfect in-between. What happens is the patient at induction, I'm standing there and I'll have them open their mouth.
I'll have you give me a really, really big ah.
And just as they're beginning to fall asleep, I have them open their mouth and put a little gentle pressure on their tongue base.
That's it. A little wider if you don't mind, thank you.
And I'm able to slide the oral airway in just as they go to sleep. I then move the oxygen cannula from their nostrils, where they've been breathing in and out freely, directly into the notch, where it has a very tight fit. So it can serve as a closed channel to deliver that oxygen. Since it's closed all the way to the level of the glottis, it's not going to be dissipating that oxygen throughout their oral cavity or oropharynx. And since it's closed also from the oxygen tank to the entrance of the laryngeal oral airway, we're going to get a whole lot higher oxygen concentration being delivered at the level of the airway. It stays, the airway does, throughout the case. It's extremely comfortable. Our anesthesiologists will leave little small boluses of propofol during the case to continue to have the patient sedated. And interestingly, it's so comfortable, basically, that as the case is done and they stop giving the sedation, it's not unusual for a patient to sort of, just kind of wake up and kind of look around.
We're just going to take this out, okay?
And we'll say, open your mouth, and we can pull the airway out. Very comfortable and simple for them, unlike a patient, say, gagging and coughing on an endotracheal tube or having something in contact with the glottis when they wake up, which is a very negative experience for patients. So it gives them a smooth, much less invasive anesthetic, a whole lot less anesthesia in general, a whole lot less needed in terms of narcotics or benzodiazepines, can kind of give you a propofol-only anesthesia. And since that wears off without the patient feeling much sedated, that hastens their recovery, allows them to get to their car and go home much faster. All those standard post-operative problems, sore throat, nausea, prolonged recovery, are really just gone when you use this airway and this type of sedation.